Hey everyone, good afternoon. My name is Ann Conrath with Avant-garde Health. We're so excited that you're here for our next webinar within the CMS TEAM Learning Collaborative that we're hosting. And the topic for our webinar for this afternoon is going to be on Gainshare. That has definitely been a hot topic in a lot of conversations we have had with health systems, in that the appetite, I think, has begun to shift in the desire to have a gain share agreement specifically within teams. So we're excited to share a bit more information there on that topic. And then we have two representatives from ENCARE who are going to speak about the importance and value of implementing ERAS within surgical care, specifically within team, and how that's going to impact your performance both clinically and financially. So really, really excited for that conversation. Brief introductions. I had shared that my name is Ann, Director of Sales here at Avant-garde Health. I have a ton of, my background is in value-based care and implementing bundled payments. So I'm really, really looking forward to the team program that's going to start here in just a couple of weeks. So now we're in the final countdown, which is exciting. Porter, I'll toss to you.
Yeah, thank you, Ann. My name's Porter Jones, and I'm the Chief Medical Officer of Avant-garde. Excited to be here to speak about Gainshare. For about 7 years, I worked in traditional hospital administration, managing and overseeing a rather large Gainshare program. So looking forward to that portion of the discussion today. And I'll hand it over to Derek.
Yep. Good afternoon, everybody. I'm the CEO and founder for Avant-garde Health.
Excellent. A little bit about our CMS Team Learning Collaborative for folks that may, this is the first one that you've had an opportunity to join. We've been facilitating the collaborative since May with monthly educational webinars, and all with the goal and the purpose is to connect folks who are doing this work with one another across health systems. And really the spirit of this is to support organizations be successful in bundled payments. There's a lot to know. The to-do list can be very long, and we're excited to connect different organizations together and figure out what you need to prioritize. No need to reinvent the wheel. Folks have been doing this work a long time, certainly for organizations that did participate in BPCI about 10 years ago. So yeah, really excited that you're here, and we have a host of assets that we do share via Dropbox. I know that some organizations can't access Dropbox totally fine. I will send them to you manually, but there's a lot of rich information in there. We have all of our recordings of all of our webinars that we've done, the presentations, and then two new assets that I want to highlight specifically that have been a ton of interest for a lot of our team customers and team collaborative participants is the HCCs for the team HCCs by bundled type. So what HCCs are going to be relevant by bundled type, and then also the HCC impact on the target price. So those are two really awesome assets that are included in the dropout links. Everybody will have that in our follow-up email. So just want to do a special shout out there, and that we will have an upcoming webinar in December, kind of as a last one, certainly before team starts on January 1st. So yeah, those are all of our announcements. And then another housekeeping thing that I want to share with y'all, that you are muted, but this is a conversation in addition to a presentation. So if you have questions or things that are important to you, please put them in the chat. I'm going to be moderating that. So within our next portion of the presentation, it's going to be on Gainshare. So as Porter's going through that information, please enter your questions into the chat, and we're going to get to those at the end of when he has kind of his slide presentations. And same thing for the ERAS portion of the presentation as well. Cool. With that, Porter, I will toss to you.
Thank you, Ann. Wonderful. So the month of October coming to an end, but this is Gainshare 2.0. If you remember and were able to join us last week, or last month, Derek went through some Gainshare information and how to set that up from a calculus portion, or from a calculus idea, how to parse that out from physician to physician and really look at this, from a way that drives engagement. So we're going to go from a little bit higher level perspective this month in looking at overall organization and functionality of a Gainshare program. As I mentioned, I ran a Gainshare program for about 4 years. So it wasn't specific for a bundled payment program, but it was a very interesting journey, a very organic process, I would say. So some learnings that we'll be able to share here, and hopefully that it is applicable to what you're thinking about as you begin on this journey of CMS Team. Now, ultimately, Team is unique because the purpose of it is to create shared accountability throughout that entire process of the patient journey that is begins with you and ends, as they leave their post-acute care care. So we want to have that accountability and that engagement flow all the way through the clinical team as well. This is a tool. It is not the tool, and not everyone is going to engage in a Gainshare program, but it is a tool that can be used to drive success in the program. So we'll go through some of those options and how that looks, really focusing in as well on the importance of data, the importance of measuring what is going on in the program, and not only measuring, using that data to actually highlight where improvements can be made and where that additional engagement can be had with the clinical staff, and then how that rolls into and achieves shared savings for the hospital, and providing that value-based care across the board. Now, as we look, Team provides a slightly different perspective. A very traditional Gainshare program like I was engaged with was hyper-focused on decreasing cost of the surgical episode within the OR, slightly around at that perioperative portion. Looking at the spend on supplies, looking at operational efficiencies. The team and the opportunity to have a program like Gainshare within the team program is unique because now we're looking at well before the patient arrives to the hospital, some engagement, and also well after. And so we want the physician and the surgeons to be involved in that process, because that is going to be better for the hospital for ultimate reconciliation, and we hope it is much better for the patient as well. An additional item, quality and outcomes are part of this program, and so we want that to be a focus and something that is discussed and part of a Gainshare program. And then we have heard from our past panelists and guests that there is a big aspect to care redesign, creating protocols, really making this specific to the patients that are going to be part of Team. And we want that also to be one aspect of the Gainshare program as we're looking and digging into this a little bit more. Some key design elements. What does the pool look like? So, as Derek had brought up last month, really easy if you want to go nuts and bolts, nothing more, nothing less, just use CMS reconciliation. Use that as your baseline. What does the eligibility look like? Well, we can have eligibility based on volume and based on seeing team patients, but also physicians being willing to participate in more than just the surgery. That pre-op, that post-op optimization, being part of that care redesign. We heard from Dr. Chip Davis and Penn State what they were looking at in some of their care redesign and protocols. And it required a lot of input and coordination from a clinical perspective, not just on the administration side. He highlighted the idea of, well, maybe there is opportunities to keep a patient 1 or 2 additional nights in the hospital to drastically decrease the time spent at a SNF, or maybe even completely avoid the SNF. He also talked about the idea of how do opioids come into play when looking at discharge disposition and readmission. So there are care protocols that are going to be much better designed if you have the entire group involved, creating consensus statements and working as a team to come up with the best protocol and best design for your specific institution as a group. And then distribution rules. This hits a little bit on what we had discussed last week. Looking at a percent allocation tied to volume. Looking at a percent distribution allocated to your portion of the reconciliation. And then there's the clinical participation and quality adherence. One thing that I learned is as we rolled out our Gainshare program, we started the pilot with a relatively small number of physicians. It was about 20, and that quickly grew as we had a few learnings within the few months. But what we quickly noticed is the financial component alone drove engagement and drove change for about 12 to 18 months. The Gainshare was almost exclusively focused on the financial component, the cost savings, and what that was looking like from a hospital and a shared savings perspective with the clinical staff. That got stale after a while. You got into a system where the care that had been designed, the protocols that were created, really were now flowing well, and it was due to the work that was done up front. So we began to tweak it, and this was the comment about it being very organic. We began pulling in these other items, like the quality and outcome items, like implementing new care protocols. We even began rolling this out to include items like research and items like education. Now, that may not be applicable to team, but just this idea of being able to compensate or add in different metrics to the Gainshare program that begins to roll away from it being exclusively and solely focused on the finances can be another way of engaging the clinicians to promote the best care possible for the patients. Now, as you can imagine, having the clinicians and the surgeons involved in the post-acute care process is extremely important. So we're looking at, getting them involved early from that pre-op optimization, understanding what do the comorbidities look like of a particular patient, being involved at least in the care design of how to educate the patient and get those patients ready or expecting a certain discharge, and then being very active in that discharge process. Making sure that those conversations are being had, making sure that there's an understanding of the social determinants that may determine some of the disposition that is going on, but having them quite involved throughout that entire process, including that readmission. I know at Avant-garde, we hate to see readmissions with a diagnosis of pain. That is 100% avoidable, whether that be through the team that the physician is overseeing or the physician itself. Those are items that can be avoided. So being able to engage in that process all the way outside of those 30 days is important. And then these early therapy protocols, and we're going to hear much more from Rasmus and his team, but adherence to protocols such as ERAS that are shown to improve patient outcome, that are shown to decrease readmissions. These are items that if you're not currently working with, are new, are going to add a layer of focus, but having the surgeons being a part of that and having them spearhead some of that is incredibly important. Now, going back to performance feedback, benchmarking, and data, we believe that it is extremely important to have this at everyone's fingertips. Having the ability for any physician at any given time to come in and ask where they stand and how they're doing in the program, in team in general, and individually within the Gainshare program that you set up is important. So as you can see here, this is a list of surgeons that are part or that have performed CABGs that are part of team, how they fared against the target price, how they fared against their colleagues. Having this data that is available to them is extremely important. When we stood up our Gainshare program, I was amazed at how many physicians wanted one-on-one discussions on a weekly basis right at the beginning to review their performance. And it was great. They were knocking on my door. I was not having to go after them. So it was wonderful to be able to have that discussion. And I wish I would have actually had more data available at that time. But yeah, being able to sit down and say, this is where you stand. This is how you stand against others. This is what it means financially for you, and also what it's meaning financially for the program or the hospital is extremely important. And the next item to look at is, how do you actually identify and engage the physicians on where to focus? We don't want to create a Gainshare program and then leave it open and say, okay, now what? How do we be successful? there is a certain level of intentionality that needs to be had in regards to what we need out of that engagement with the surgeons. So here's a great example of looking at a national benchmark, taking a particular surgeon or a group of surgeons' performance, comparing that to top performing benchmarks across the nation to get a feel of where you actually stand. So as you look, you can see, the discharge to home rate for Dr. Vincent compared to the top hospitals is 68 to 79%. And then you see the different metrics and how Dr. Vincent compares to top hospitals. Most importantly, you're seeing the average post-acute care spend. So there's a large gap between what the top hospitals are doing and Dr. Vincent. So being able to look at this type of granularity and say, now as a group, we need to begin thinking, how do we approximate the benchmarks from a national perspective? How do we get our discharge to home to that 79 to 80% as a group? How do we decrease that overall post-acute care spend as a group? So we now have the true north. We have where we want to be focusing. Now let's sit down. Let's create those protocols together. Let's create the consensus statements, how we're going to work with the other staff members within the hospital, and how we're going to be as engaged as possible in that post-acute care portion of the patient journey. Very important to keep physicians invested. Again, I'll repeat. My learning was just the one aspect without changing anything. The baseline Gainshare program we created got stale after 12 to 18 months. Continuing to iterate on that for what your needs are from a hospital and clinical perspective is key. So continuous feedback. Have quarterly comparative dashboards. Have these one-on-one discussions with the physicians. What are they seeing? What would they like to do differently? Should we be thinking about reinforcing some of these new ideas with a financial component? Here's another aspect. Some groups do both, a Gainshare with the physician, and some, in addition to adding budget to the department, some have actually said, Gainshare is not for us, but we will add back budget to the department based on group success. So this is an idea of reinvesting a portion of those savings into departmental improvements to stand up protocols or programs like ERAS, additional tools for analysis, whatever that looks like, providing that to the physicians to make what they are doing easier for them. And then obviously celebrate alignment. Make sure that it is very clear. What I found that works very well is during service line meetings, even if there's just a portion during grand rounds, celebrating what has been done and the successes that are being had. Common pitfalls, let's focus on the entire process, the entire episode, rather than just what is going on within the OR. That is important and really the key to this program. Make sure that you have the data. Lack of transparency will kill this in 2 seconds. As you start distributing the shared savings, if not everyone feels comfortable with how it is distributed or the calculus, that'll end your program very quickly. Don't overcomplicate it. Make it easy to understand, make it transparent how that calculus is being done. And then go ahead and make sure that you allow for compliance reviews. And if that even needs to be done by an outside party, some hospitals go with that to make sure that it is audited appropriately. Key takeaways, I think it's just an overview of what has been discussed, but that high level of align the group from a goal and an opportunity improvement perspective, measure that with data, use that data to provide engagement with the individual physicians and the group as a whole. Then there's obviously the financial reward. And then finally, to complete the virtuous cycle, continue to improve and iterate on what has been going on so that it is not a stagnant program. Make sure that it is fully organic and changeable when appropriate. And I'll hand it back to you. I know we're open for a few minutes of Q&A, and I know Derek is here as well if there's any questions about the calculus that we discussed last month as well.
Yes, thank you. We have quite a few questions from the chat, which I'm really excited to address. So the first one was, what resources are available to show hospital administrators that surgeon involvement in gain sharing program will actually save the hospital money? I love this question. Yes, there are quite a few resources and publications on this topic about the outcomes when you do have surgeon gain share. Actually, Derek has co-authored a couple of those. And so Derek, yeah, any more comments there about just kind of the evidence that gain sharing works?
Yeah, I mean, the quick answer is like we've observed, like with working with organizations that haven't done gain sharing and then have implemented gain sharing, like what is the incremental, uh, you know, reconciliation payments achieved in those situations, and it can certainly be like something like where physicians, again, depending on the type of episodes here in the team, will be surgical episodes where physicians often have like a fair amount of ability to influence the outcomes, and so like the savings can be quite substantial in those cases. And then again, like there's the ability through analytics to like specifically quantify individual physicians' contributions to the program as well, like on a patient case mix adjusted basis, like look at how much each physician contributed towards any positive reconciliation or net losses for their cases. And we're happy to walk through that math with anybody who's interested to learn more about it.
Yeah, and I've also seen firsthand, just in my experience in implementing bundles with GainShare with hospitals, that yeah, it has significantly decreased the overall cost. And that was within BPCI. So all to say is that I think there's of course a variety of ways to engage surgeons, and especially with I think the work that team entails in terms of the difference that the care will be, the new addition of protocols and pathways and looking at data. That is definitely something that we recommend strongly consider in terms of getting your surgeons engaged and having them leadership and accountability within the program.
We can share this as a follow-up as well, but there's, as I mentioned, we wrote a Harvard Business Review article with one of our clients in the BPCI Advanced program that was able to achieve basically savings 15% below the target prices set by CMS. And like one of the key tenets of their success was entering into like financial alignment with their physicians in the program.
Yes, we would love to share those if they're not already included in our Dropbox assets. Another question from the group: can gain sharing be linked to volume of encounters or procedures? Yes. I know in previous gain share models that I've implemented, it's been a percentage of their Medicare spend. Just a kind of as a proxy for volume. So that's kind of the short answer. Derek and Porter, anything to add there?
Yeah, I mean, there are definitely like legal implications relative to just doing things in relation to purely based off of the physician volume. We do think like the ideal way to structure it is basically as a percentage of like their contributions to any program reconciliation payments that are received at the hospital health system.
Next question was, do individuals who perform well, do they get gain share? Do they get a payment if the program as a whole does not realize gains? In my experience, no. Like if the team collectively, if the organization collectively has not had a positive NIPRA or a positive bonus payment at the end of a performance year, then no one's getting a payment. So that really facilitates kind of a team like approach and collaboration where we want to make sure that the rising tide raises all boats, if that's the right way to say that phrase. But the point being is that we want to make sure that surgeons that are not performing to benchmark or as good as their peers, we want to make sure that we're all in this where we have a collective interest in quality being improved and cost being decreased for every single surgeon that's going to be in the program.
And I think just to add to that, if we have one very successful surgeon and everyone else is or below and not contributing to the reconciliation, to me that tells me, as you mentioned, protocols are not being developed as a group. They're not being followed as a group. It just is still these isolated islands working individually, and that really defeats the purpose. It also defeats the purpose of CMS team. You really want to have all these unique islands come together as a unit, for the betterment of both, the financial health of the hospital and the patient. So it really is telling if that's the case.
The next question was, and thank you, Danielle. Anne mentioned that she doesn't recommend gain sharing with PAC partners. However, since Team is now for the first time permitting gain sharing in the post-acute care space, and PAC utilization remains the largest driver of potential savings, shouldn't organizations be exploring this opportunity? For sure. Absolutely explore it to see if that would be a good fit for your organization. For me personally, in my experience in doing this work, it wasn't required. Giving your bonus payment that y'all have worked really hard to receive and needing to pay skilled nursing facilities or home health agencies, in my experience, was not required for them to be good partners with you, meaning that they're abiding by your protocols. They're being good communicators with your case management team, that they're not calling 911 for and sending your patient to the emergency room when they could coordinate with your internal team to get them a same day appointment, as an example. So that's just been in my experience that a payment to your PAC providers is not required for them to be good partners with you. But if that's something that your organizations wants to explore, absolutely. These are just recommendations that I offer folks as they're thinking about, what should we do or not do, or, what should we prioritize? Um,
Just
so
building
yeah,
up what Anne's saying, I'd say it depends a little bit on just like, how many of those pack provider types there are in your area, and like basically how much leverage you have, relative to, I mean, like for the pack providers, the biggest motivation is getting more patients sent to them. And so like if there are other alternative options, like where if a given pack provider isn't meeting your standards relative to like length of stay or other things that you're trying to work with them around, and they're feeling like there's that risk of those patients then going elsewhere, that's a much more powerful motivating factor than the gain share. But if there's only like, one or two, or they're all at capacity, and so like you don't have as much leverage in that situation, then doing some sort of gain share with them, definitely could be advantageous.
Mhm.
yes, well said. And that, Rhonda, relates to your question of, do you see gain sharing with post-acute care? I personally have not. I don't know, Derek and Porter, if you have any other experience with doing gain share with PAC providers. I
It,
had
yeah,
never worked with anybody who's
we've
done that.
seen it in limited circumstances. Again, typically like where there's just like, fewer choices in that particular metropolitan area.
Yeah. And then the final question we have is, what percentage of your savings came from implants and what percent came from more efficient usage of certain items? So I think, Porter, this is just in relation to your gain share experience
Yeah,
for the inpatient costs.
yeah. I mean, as we all know, the inpatient costs will be less. Won't have that direct correlation to the reconciliation, but it will help your margin. We find, going after the larger items like implant usage, vendor renegotiation is your big bang for the buck at the beginning, but we still drive a lot of efficiencies from a supply cost perspective going downstream after that. And in parallel, we like to look at operational efficiencies as well. So think of OR time, length of stay, PACU time. All of these will add savings to the bottom line and increase margin. So it is not a one and done in regards to your ability to find areas to improve from a financial perspective.
Yeah. One other question that we had gotten was in regards to employed versus contracted surgeons for gain share. I'm really glad someone asked this question because this has been a really popular discussion, certainly with all the health systems that we've talked with. And what's the recommended strategy there for gain share? Is the kind of the gist of the question. So
Yeah, I can give you my perspective, and then Derek may have another thought as well. For me, it was most effective with the non-employed physicians. We had a large clinical group. We had to have a mechanism of not only managing them, but engaging them. So it wasn't a run through the door, perform the procedures, and run right back out. So for our intent, it was most effective with those that were not employed.
The one nuance I'd add is from an incentive perspective, it doesn't necessarily need to be like, direct compensation to the physicians either for it to be effective. Like, I mean, ultimately, people just want to know that they're doing something that's valued and recognized for the value they're helping, if they're going above and beyond like what's part of their normal part of their job responsibilities. And so, we've seen many health systems like offer additional resources and support to departments that, engage and help drive improvements even with employed physicians. Or, some people prefer like having ability to go home earlier or finish earlier. Like, so there's different ways you can incentivize and motivate people. And it oftentimes it's not necessarily about like the exact dollar amount too, but it's more just like the symbolic effort or gesture of like, recognizing people. And so even like small amounts of money can still be, appreciated and help motivate people as well.
Absolutely. Excellent. Well, those are all the questions that we got in the chat. So thanks you all so much for asking those. And if things come to mind, please continue to ask them. We're always a resource here on this topic. But without further ado, Rasmus and Lada, I will toss to you to bring us through ERAS and the importance of ERAS specifically within team.
Thank you very much. I'm trying to rearrange things here. Yeah, so thank you very much. And to be here today. My name is Rasmus, the CEO of ENCARE, and with me here today I have Lotta as well. Hello, Lotta. And for those guys, ENCARE has been working with ERAS Society for the last 15 years, making sure that ERAS is properly implemented, and we're doing that on all 5 continents of the world. And I think your presentation, Porter, aligns very well with what we are going to talk about next 8-9 minutes. First, a disclosure: ERAS is the trademark of the International ERAS Society. I will do a quick intro, then talk a little bit about what is ERAS, that it actually works, the most important things of ERAS, and how ERAS comes into team, and then some final remarks. So first introduction, which you touched upon also to some extent, Porter, is team changes. Some things here in a way. I don't know how to decrease that. Changes the financial rules of surgical care. The margin now depends on reducing episode cost without lowering the quality. And that means that you need to be able to achieve that, you need to control your care processes. And I will get back to that many times during this presentation. ERAS, if you are not familiar with that, ERAS has been around for some 20 years. There are some 10,000 peer-reviewed articles on ERAS. All started with the ERAS Society, starting to publish guidelines some 20 years ago. And it is really the golden standard for perioperative care. It's about the multidisciplinary aspect of the complete patient pathway, and it's about continuous improvement, data-driven continuous improvement, and about enhancing recovery and reducing complications. And from a more medical perspective, it's about reducing stress. Being under surgery is a lot of stress. So how can we prepare the patient in the best way and then make sure that they recover as fast as possible? And these are the results when ERAS is properly implemented. And these different reduction in complication, etc. It's coming from peer-reviewed articles in the most prominent journals. So it's a huge effect if you implement ERAS properly. That was from a clinical perspective. From a financial perspective, this is from an article from Alberta, where they showed that you put in $1 and you get up to $7 back, which is rather impressive results. If we look for the few specialties part of TEAM, if you look up colorectal surgery, you can see that you reduce the length of stay with 30 to 40%. You reduce the very common complication on a stomach leak with up to 40%. And I mean, in a TEAM context, reducing complications with 40%, increase patient satisfaction, and ready for discharge are extremely important things to keep track of. The same for hip and knee orthopedics. You will reduce your moderate to severe complications with 26%, and you will also increase the patient satisfaction. And also for cardiac, as just a few examples, you can save a lot of money, been shown in studies, but also reduce a very expensive blood transfusion rates and reduce a few other complications. The trick with ERAS, and I think there are a lot of misunderstandings about how you should go about implementing ERAS, is really about this. Evidence is an evidence-based concept. You cannot cherry pick and expect the same results. Look at the soups on the left and the right. If you just omit a few ingredients, it's not really the same soup, right? And it's not evidence-based. And I think that's a mistake that many people do when trying to implement ERAS. They just take a few things that they feel comfortable with. So it's all about adherence and compliance to drive the optimal outcomes. It's been shown in several studies, here one on the right, that if you have a compliance to the protocol, to the guideline with more than 70% or higher in a consistently, then you will get those complications I talked about a few minutes ago. There's really this dose-response relationship. And I think what is also important is that, and that's also another misunderstanding, is that the more complicated cases you have, the larger the ERAS effect would be in terms of improved outcomes. So it's not that you should cherry pick a few patient types, a type of surgery. You should actually do all your patients as ERAS patients. So to be able to control your team performance, I mean, if you have a lot of variability in the provided care, that will lead to unnecessary complications. And if you don't know your adherence to the protocol, it's not measured, it will be impossible to improve. And you have to make sure that, as also mentioned in Port's presentation, that the clinical pathway needs to be owned by the clinical team. Otherwise, you will not really have a control of the 30-day readmissions. It's about preventing complications early on. You will have too many discharges to various post-acute institutions instead of home, and you will underperform on your team quality metrics, for example, the complication levels. So what you need to do is really, it's all about how can you empower your clinical teams to start re-engineer your pathways in line with the golden standard protocol for perioperative care. And you need to give your teams the tools to really measure, improve, and then sustain this high protocol adherence to be able to get those good outcomes with lower costs. So you have to make it a system. It's not a project that you run for 6 months or 12 months. It's something you do continuously, and you will never reach 100% compliance on all care elements. You have to have this multidisciplinary ownership. You have a lead, and then you have your core team, but it's not only a surgeon, it's also anesthesiologist, the nursing, the rehab, etc. And you have to make sure that what you were showing a presentation with dollars before, you have to make sure that everyone has the same we have the same currency, we have the same definition of the different care elements. And if you want to compare and benchmark with others, you should not have made up your own definitions of the different care elements of the guideline. And measure, track compliance to each care element, ERAS element, and the outcomes. And you need to have both of them to be able to improve. Ideally, you start with measuring your baseline, and based on that, you identify the most high impact gaps, and then you run quick and fast improvement cycles. This is an example of a team where we have the baseline measurement in pinkish here, and you should be as close to the outer rim as possible. Then is when you have 100% compliance. We have standard care for the different elements. And then a post-implementation where you can see that there are many more elements which are actually standard care. This is a typical where you start, try to understand that. And the other thing, it's not enough just to know your compliance and know your outcomes. You need to understand why you have different outcomes. One example of this is if you look this team looked on IV fluids versus complication. And as you know, fluid management, fluid overload is really important. So we are just showing two different patient cohorts. One where you have weight change, which is not compliant with the protocol, meaning that the patient has been giving too much fluids, and the other one when they are compliant with the protocol, and the implications are really important when it comes to complications, whether you are compliant or not. So some final words. ERAS is not just a clinical program, it's really your strategy if you want to thrive under team. We really think that it's really the ERAS and team is really like a hand in the glove, given the way that team is set up. ERAS will target the same kind of cost drivers as in team. And we know, and it's been proven over and over, that the higher compliance, ERAS compliance, the better team performance. And it works. It's been proven in everything from smaller rural hospitals to health systems like Mayo or Kaiser or Charité. And yeah. So final words, few things to remember. Make sure that you control your care process. That will lead you to control your outcomes. And if you control your outcomes, you will also control your costs. Thanks.
Wonderful. Thank you, Rasmus. This is interesting. We've seen in practice the power of adherence to ERAS and what it can do. I'd love to get some more detail from you, Rasmus, when we're really looking at items like length of stay, readmissions that are applicable to team. What is it? What is actually going on the pre-op, the op, and the post-op aspect of care that is altering those, that is improving or decreasing readmissions, improving the speed to recovery? Could you give us a few examples of what is being done, kind of on that themes of the protocols and implementing protocols that are best for the patient?
Yeah, I mean, first, as I said, I mean, it's about the whole package, but I mean, some of the things that maybe old truths is that, I mean, you should not have overnight fasting. You should try to do the other way around. You should prepare, you should boost the patient with carb load. The other thing is patient education, making sure that you set the expectations with the patient that the discharge will actually be slightly faster than maybe they expect. And then afterwards that you mobilize very quickly directly after. But it's a lot about expectations for the clinical team and for the patient. I don't know, Lotta, if you would like to add something to that.
No, I think it's a good summary, but to emphasize that all the different care elements, and we saw an example here from the colorectal protocol, is that they are connected. Also, they impact one another. So it's really important to understand that cherry picking should be avoided. And it's when you do ERAS, a full ERAS, is when you can expect the full benefits. So, and there is likely, we have started to do machine learning on the data, and there are different elements impacting different patients in different ways, depending on where they come from and their physiology and comorbidities. But the package that we have in the protocols and that is based on evidence is really what you need to focus on to achieve the full benefits.
Great, thank you. Can I go back to, you mentioned something then, Rasmus, about expectations for the clinical team, and then you mentioned expectations for the patient. Tell me how that works. When do those expectations get set with the patient? At what part in the process? And how does that change, from your perspective, the care that the patient receives?
Yeah, I mean, we're working in many countries where they're expecting that they should be in the hospital for 10 days. And it really, in the early phase of the first encounter in the hospital, that they get this patient education and then continuously through the pathway and after. But it's really early on, and I guess, yeah, it's cultural, the expectations, how long you will stay in the hospital, right? And I think we have seen the same effects on the clinical team as you have seen with the financial data that you showed that, when they are presented with the data, they really understand, and there's a financial aspect of gain sharing, but you cannot underestimate the joy for clinical personnel when they see that they're really helping saving lives, because they are continuously improving their process.
Yeah. One thing that I find interesting in observing hospitals that are part of the ERAS program is, for those that are not doing it, it gets into the nitty-gritty of the patient care. I mean, they'll look at the temperature of the patient in the OR, whether certain types of blankets at certain types of temperatures should be used, carb loading before through different types of fluid mechanics. You mentioned fluid overload, which can cause a problem from a clinical perspective. How long does it take, in the PACU to come to? So there's a lot of nitty-gritty things that all compound to allowing that patient to recover in a much quicker fashion, which will result in success in the TEAM program. But yeah,
I mean, you cannot expect excellent results if you are very picky with all the details, So yeah, it's.
Yeah, no, I appreciate that. One last thought, Rasmus, if you would like to give, just one summarizing piece of advice to the group as they prepare for TEAM, thinking about protocols from a quality and outcomes perspective, and from an ERAS perspective, what would be your final suggestion and piece of advice?
Well, make sure that you, obviously TEAM will be anchored in the top of the organization, but make sure that it's, you find a clinical champion, it's anchored with the hospital management, and then start with a few of the service lines where you have high volumes, and it's better to do it properly with one service line than do the kind of implementation, because then ERAS will be a cost center, not a profit center, I would say.
Yeah.
So it's do it properly. I mean, quality requires hard work, unfortunately. There are no shortcuts.
Yeah. No, I think that's great advice. And that all goes back to having an engagement from the clinical staff, not just the surgeon, but everyone that is involved.
Yeah.
I think that is something that I appreciate about ERAS, is it tends to bring many different individuals that are very key individuals in the care together under one protocol, one vision. And I think that's great for the patient.
Yeah, no, so I mean, it's evidence-based, so that's easier to convince clinicians about something if it's evidence-based, right?
Right. Yeah. Wonderful. Well, thank you. I appreciate Rasmus, you and Lotta joining us and giving us insight in how ERAS can translate into financial success in team. And really, you know, focusing in on that aspect of quality, evidence-based care, you know, that ends up being good for the provider and for the patient. So thank you for joining, and Anne, I'll turn it back to you.
Awesome. And then y'all did receive a couple of questions. One of them was, is there an ERAS care pathway defined in Epic or Agile MD?
No. I mean, we have an audit system which is can integrate to Epic, but the ERAS guidelines, they are free of charge. You can download them, but please make sure that you stick with official ERAS Society interpretations of that if you would like to be able to benchmark with others and not reinvent the wheel.
Mm. And then one comment from an attendee said that in the past we have seen the cherry picking of components, and they appreciated your comment that it works if it is all the components for all patients. So yeah, just wanted to share that comment here. And then another question was, are you familiar with the perioperative surgical home as a potential addition to ERAS?
No, we're not, unfortunate. No.
Okay. Okay, fantastic. Wonderful. Well, I think that concludes all of the questions that we had gotten from the group for this portion, which is fantastic. And then just with parting notes for the group, I know with we're still supposed to be receiving an additional data set from CMS with updated target prices and baseline data. I know organizations already have baseline data to analyze, and so just wanted to share that if we can support folks, and especially for collaborative members, to ingest your data into our analytics platform to support you in that analysis about prioritizing what needs to be improved upon ahead of January 1st, we would love to do that for you. We've done that with a ton of organizations, so please let us know how we can support you. And yeah, we'll be sending out the recording for this and then the Dropbox link for the assets. Please email me if I can send them to you manually. And yeah, that concludes our time for this afternoon. And I hope everyone has a delightful Halloween. So thank you so much for joining us, and we're excited to talk with you in December.
Thank you.
And guys, thank you. Bye-bye.
Bye.